Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 255 of our pharmacotherapy series, which majors in sexually transmitted diseases. The first question reads: T.D.S., a 23-year-old male naval officer recently stationed in the Philippines, complains of dysuria, meatal pain, and a profuse yellow urethral discharge for 2 days. He admits to extramarital sex with a prostitute during the past week. He is accompanied by his pregnant wife, A.C.S., who is asymptomatic. T.D.S. engages in vaginal sex, but there is no history of oral or anal sex with either partner. Assuming the prostitute has gonorrhea, what is the likelihood that T.D.S. and A.C.S. have been infected? After 1 or 2 episodes of unprotected vaginal intercourse with an asymptomatic infected prostitute, a man has approximately 50% risk of acquiring a urethral infection. The risk increases with repeated exposures and high prevalence among commercial sex workers. The prevalence of infection in women who are secondary sex contacts of infected men is as high as 80% to 90%. Therefore, the likelihood that T.D.S. and A.C.S. are infected is high. Because T.D.S. had sex with a prostitute, both T.D.S. and A.C.S. should also be tested for HIV infection. The next question reads: what signs and symptoms in T.D.S. are consistent with the diagnosis of gonorrhea? Describe T.D.S.'s anticipated clinical course if he remains untreated. In men, gonorrhea usually becomes clinically apparent 1 to 7 days after contact with an infected source. A purulent discharge associated with dysuria is the first sign of infection. T.D.S. exhibits both. The discharge, which is presumably caused by chemotactic factors such as C5a, released when antigonococcal antibody binds complement, may become more profuse and blood-tinged as the infection progresses. Some strains of gonorrhea have a propensity to cause asymptomatic or minimally symptomatic infection with negative gram stain. Patients with asymptomatic or minimally symptomatic disease may serve as reservoirs for the infection, evading treatment for prolonged periods. At one time, only women were thought to have asymptomatic gonorrhea, but now it is known that men may be asymptomatic carriers as well. In the area before antimicrobials, gonococci occasionally spread to the epididymis, causing unilateral epididymitis. The prevalence was 5% or more in patients in some studies. Now epididymitis occurs in less than 1% of men with gonorrhea. Urethral stricture after repeated attacks and sterility after epididymitis are rare complications of gonococcal infection owing to the effectiveness of antibiotics. The next question reads: intracellular gram-negative diplococci were seen on the gram stain of T.D.S.'s urethral exudate. So my question to you is any further diagnostic testing required? Demonstration of intracellular gram-negative diplococci in the gram-stained exudate confirms the diagnosis in symptomatic men. Until recently, some experts recommended that cultures be reserved for individuals with negative gram stain of urethral exudate. However, today cultures are recommended for all patients to permit isolation and testing of the bacteria for antibiotic susceptibility. Cultures usually are performed on Thayer-Martin medium, an enriched chocolate agar to which vancomycin, cholestyramine, and nystatin have been added. Cultures from the throat should be obtained if T.D.S. were exposed by cunnilingus to the prostitute. In T.D.S.'s case, a urethral culture is indicated. The next question reads, A.C.S., T.D.S.'s wife, is asymptomatic. What symptoms would be consistent with gonorrhea in A.C.S.? Do the symptoms differ because she is pregnant? What is the natural course of gonorrhea in women if left untreated? Urogenital gonococcal infections in women are commonly asymptomatic. Because the endocervical canal is the primary site of urogenital gonococcal infection in women, the most common symptom is vaginal discharge. Many women infected with gonorrhea have abnormalities of the cervix, including purulent or mucopurulent endocervical discharge, erythema, friability, and edema of the zone of ectopy. The incubation period for urogenital gonorrhea in women is variable. PID is a serious complication in 10% to 20% of women with acute gonococcal infection and can lead to infertility and chronic pelvic pain. The assessment of signs and symptoms in women with gonorrhea often is confounded by nonspecific signs and symptoms and a high prevalence of coexisting infection, especially with chlamydia trachomatis or trichomonas vaginalis. Although lower genital tract symptoms in women may disappear, they remain carriers of Neisseria gonorrhoeae and should be treated. Complications of urogenital gonorrhea in pregnancy include spontaneous abortion, premature rupture of the fetal membranes, premature delivery, and acute chorioamnionitis. Other complications include gonococcal arthritis conjunctivitis, and ophthalmia neonatorum in the newborn. For these reasons, it is critical that A.C.S. be worked up thoroughly for gonorrhea. The next question reads, how should gonorrhea be ruled out in A.C.S.? Nucleic acid amplification tests, abbreviated as NAATs, such as polymerase chain reaction, are recommended for the detection of Neisseria gonorrhoeae at urogenital sites in men and women regardless if symptoms are present. Although nucleic acid amplification tests are not FDA approved for the detection of Neisseria gonorrhoeae at non-urogenital sites, laboratories should meet CLIA requirements and performance specifications for use with rectal and oropharyngeal specimens. Nucleic acid amplification tests are the recommended detection method for rectal and oropharyngeal specimens. Although culture for Neisseria gonorrhoeae is not ideal for routine diagnosis, cultures should be performed for isolation and identification, antibiotic susceptibility, and resistance surveillance. Cultures should also be performed in cases of suspected treatment failures, defined as those that have received CDC-recommended treatment and subsequently has a positive Neisseria gonorrhoeae test result 7 days after treatment and did not engage in sexual activity during those 7 days. In A.C.S., a nucleic acid amplification test from anal specimen also could be performed because the rectum can serve as a reservoir for gonococci. The next question reads, compare the various drug regimens used for uncomplicated gonorrhea. Many strains of Neisseria gonorrhoeae exhibit plasmid-mediated resistance to penicillin and tetracycline. That is, they are penicillinase-producing Neisseria gonorrhoeae, abbreviated as ppNG, and/or tetracycline-resistant Neisseria gonorrhoeae, abbreviated as TRNG, respectively. In addition, significant levels of chromosomally mediated resistance to penicillin, tetracycline, and cefoxitin have been reported. In 2013, all isolates in the gonococcal isolate surveillance project, abbreviated as GISP, were susceptible to ceftriaxone. Therefore, a single dose of intramuscular IM ceftriaxone 250 mg is preferred for the treatment of gonorrhea. Cefixime 400 mg orally as a single dose is no longer recommended as a first-line treatment by the CDC but as an alternative option when ceftriaxone cannot be used. Because of the emergence of high levels of quinolone-resistant Neisseria gonorrhoeae, abbreviated as QRNG, the CDC no longer recommends the use of fluoroquinolones, such as ciprofloxacin and ofloxacin, for the treatment of gonorrhea. Because a high percentage of patients with gonorrhea are also co-infected with chlamydia trachomatis, a single dose of azithromycin is recommended to be taken concurrently for a presumed infection. Intramuscular spectinomycin, which traditionally had been used in individuals who could not tolerate fluoroquinolones or cephalosporins, is still unavailable from the manufacturer. Although limited data exists for treatment of gonorrhea in patients with cephalosporin or IgE-mediated penicillin allergy, potential alternative treatments are a single dose of gemifloxacin 320 mg orally plus azithromycin 2 g orally, or a single dose of gentamicin 240 mg intramuscularly plus azithromycin 2 g orally. Individuals who have either penicillin or cephalosporin allergies should be desensitized to cephalosporins before treatment begins. Let's now briefly discuss ceftriaxone and other cephalosporins. Ceftriaxone, a third-generation cephalosporin, is given as a single, small-volume IM injection that eradicates gonorrhea at all anatomic sites and is also safe in pregnancy. It is considered U.S. Food and Drug Administration (FDA) pregnancy category B. Ceftriaxone is ineffective against chlamydia trachomatis and in the prevention of postgonococcal urethritis, whereas ofloxacin and levofloxacin for 7 days have similar efficacy to doxycycline. Other injectable cephalosporins, notably ceftazocime, cefoxitin, and cefotaxime, have been found to be safe and highly effective, but they do not offer any advantage over ceftriaxone for urogenital infections, and their efficacy in pharyngeal infections is not as well established. A single oral dose of cefixime 400 mg is also effective in curing 92.3% of uncomplicated urogenital and anorectal gonorrhea infections. However, in 2012, the CDC no longer recommended cefixime as a first-line regimen because of concerns about declining cefixime susceptibility among urethral Neisseria gonorrhoeae isolates in the United States during 2006 to 2011. Other oral cephalosporins, such as cefpodoxime and cefuroxime, are not recommended because of inferior efficacy and less favorable pharmacodynamics. However, they are FDA approved to treat uncomplicated Neisseria gonorrhoeae. Next we will look at the fluoroquinolones. Fluoroquinolones have been routinely used since the 1990s for the treatment of gonorrhea. However, the GISP has continuously documented fluoroquinolone resistance in Neisseria gonorrhoeae isolates, which has necessitated changes in the CDC sexually transmitted disease treatment guidelines. Because of this increased resistance, the CDC no longer recommends ciprofloxacin, levofloxacin, ofloxacin, or other fluoroquinolones for the treatment of gonorrhea. This recommendation also extends to the treatment of gonorrhea-associated conditions, such as PID. Regarding prescribing patterns, the CDC's 2013 Sexually Transmitted Disease Surveillance Program observed that 96.9% of treated patients received ceftriaxone 250 mg. The number of those treated with cefixime decreased from 5.3% in 2011 to 0.02% in 2013. This decrease in cefixime use was expected as CDC recommendations to avoid use of cefixime at any dose as first-line therapy was issued in 2012. Other most prescribed medications, followed in order by ceftriaxone, azithromycin, other less frequently used drugs, and cefixime. Dual therapy with azithromycin or doxycycline was prescribed in 95.4% and 4% of those treated with ceftriaxone, respectively. The next question reads, how should T.D.S.'s urethritis be treated? Because A.C.S is totally asymptomatic and the results of her cultures are pending, should she be treated empirically? If so, what or drugs would you recommend? Because T.D.S. has gonococcal infection limited to the urethra, which is considered uncomplicated, a few treatment regimens are possible. Ceftriaxone is the preferred treatment with cefixime as an alternative, only if ceftriaxone is not available. Quinolones should be avoided because of increased resistance in Neisseria gonorrhoeae and because T.D.S.'s infection was likely obtained in the Philippines, where quinolone resistance occurs in more than half of all isolates. Patients with gonorrhea may also be co-infected with chlamydia and therefore presumptive co-treatment with azithromycin 1 gram orally as a single dose could be initiated if co-infection is suspected. Although single-dose azithromycin 2 grams monotherapy has been used to treat concurrent gonorrhea and chlamydia, it is more expensive and poorly tolerated because of increased gastrointestinal side effects and may lead to macrolide-resistant Neisseria gonorrhoeae, or treatment failure. Regarding sexual partners, A.C.S also should be treated even though she appears asymptomatic. All partners who have had sexual exposure to patients with gonorrhea within 60 days should be treated. If the patient has not been sexually active for 60 days, the most recent sexual partner should be treated. This is especially true when the partner is pregnant because gonorrhea during pregnancy is associated with chorioamnionitis and prematurity, as well as neonatal infection. Pregnant women can be treated safely with cephalosporins and azithromycin for gonorrhea and chlamydia. The next question reads, how does one determine whether the drug therapy of gonorrhea has been effective in T.D.S. and A.C.S.? If recommended therapies are used for treatment of uncomplicated gonorrhea, a test of cure is not necessary for either A.C.S. or T.D.S. because cure rates are close to 100%. However, a test of cure should be done 14 days after treatment in those with pharyngeal infection treated with an alternative treatment regimen. If symptoms persist in T.D.S., who was treated with ceftriaxone, cultures should be done to determine antibiotic susceptibility, and to rule out other causes of urethritis. The next question reads, T.D.S. states that he was treated with penicillin in the past for a gonococcal infection. Why are penicillins not prescribed routinely today? Failure of penicillin to eradicate the gonococcus can be the result of plasmid, e.g., ppNG, or chromosomally mediated resistant Neisseria gonorrhea, abbreviated as CMRNG, antibiotic resistance. ppNG contain plasmids, which determine the production of lactamus, an enzyme that hydrolyzes the lactam ring of penicillin G or ampicillin. Chromosomally mediated resistance does not involve beta-lactamase production and often is associated with increased resistance to other beta-lactams. The clinical significance of CMRNG is questionable because serum levels of approved antibiotics are achieved far above the minimum inhibitory concentration, such that treatment failure is unlikely. However, to date, CMRNG remain largely susceptible to ceftriaxone. High-level tetracycline resistance is defined by gonococci that carry plasmid-encoded resistance to 16 grams per milliliter or more of tetracycline. These strains are known as TRNG. Although not of major concern in the United States, development of resistance to alternative therapies is a continuing concern. The first cases of PPNG infection were reported in the United States in 1976. PPNG are especially prevalent in Southeast Asia, the Far East, and West Africa, where the prevalence often exceeds 50%. In the United States, the percent of PPNG strains reached a peak of about 11% in 1991. Since then, cases have steadily declined to 0.4% in 2007, according to the CDC's GISP. Strains of TRNG were first identified in 1985, but fortunately most TRNG isolates still are sensitive to beta-lactam antibiotics. The use of tetracycline was officially abandoned by the CDC in 1985 and penicillin was abandoned in 1987. In the late 1990s, the number of TRNG and PPNG plus TRNG cases plateaued at about 5% and 1%, respectively. Therefore, because approximately 21% of gonococcal isolates are resistant to tetracycline and/or penicillin within the United States, it is not acceptable to use these agents in the initial management of uncomplicated genital gonorrhea. Ceftriaxone remains the drug of choice. Antibiotic susceptibility testing is recommended in cases of persistent infection after treatment. QRNG was first reported in 1990 and was reported to be 0.2% of isolates in the continental United States. In the 2013 GISP report, 11% of isolates from Honolulu, Hawaii, were QRNG, whereas among California sites, 31.8% to 44.4% of isolates were QRNG. Neisseria gonorrhoeae resistance to quinolones has increased almost every year since reporting began in 1990 and has become widespread in the United States, resulting in the CDC recommending against using quinolones for the treatment of gonococcal or related conditions, e.g., PID, acquired in the United States. In 2013, 16.1% of all isolates collected by the GISP demonstrated resistance to ciprofloxacin. Resistance to fluoroquinolones is associated with mutations of GYRA, and is commonly identified in strains that produce beta-lactamus and strains exhibiting chromosomally mediated resistance to penicillin and tetracycline. Neisseria gonorrhoeae strains may therefore exhibit decreased susceptibility or complete resistance to the recommended dose of quinolones, and the clinical importance of strains with decreased susceptibility is unknown. T.D.S. was likely infected with Neisseria gonorrhoeae in the Philippines, and QRNG is highly likely. Thus, an appropriate cephalosporin antibiotic such as ceftriaxone should be recommended. If he had been initially treated with ceftriaxone, the expectation would be that he would be free of gonococcal infection within 3 days. To date, ceftriaxone-resistant strains of Neisseria gonorrhoeae have not been reported in the United States, but GISP data has documented decreased cefixime susceptibility among urethral Neisseria gonorrhoeae isolates. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 256.